So a urethral stricture is either from a congenital anomaly. They were born without a urethra, like in what's called hypospadias, or they had a traumatic injury, either from a catheter. They had a catheter for some other surgery. Let's say they had a abdominal surgery or even heart surgery, and they put a catheter in, and then there's an injury of the urethra, and they develop scar tissue weeks or months later. The other possible is from a traumatic, like a car accident or a fall, where you have a straddle injury and you injure the urethra. So most patients, to tell you the truth, are managed fairly minimally invasively initially. In other words, this is usually the male urethra, because the male urethra, is about 20-something centimeters, while in a woman it's very short, a couple centimeters. So there are women who develop urethral strictures, but it's very rare. Men, it's not that common a problem. And many of them can be managed endoscopically with a telescope, but it's the ones that are highly complex, that are very long, or caused by an inflammatory cause, or collateral damage from radiation or chemotherapy or other surgery that makes it really complicated. A urethral stricture is scar tissue of the urethra. In other words, the urethra is narrow. And so a narrow urethra will make the urine slow, and you'll maybe go urgently or frequently to the toilet or have to strain to urinate, and waking up at night. And many times the common presentation is recurrent urinary tract infections. They keep getting recurrent infections. So many times it's misdiagnosed. Many times it's misdiagnosed as BPH or enlarged prostate, and the patients are given prostate medicine, and then they say, look, it didn't do anything. I'm still having trouble urinating. I am straining to urinate and the like. So then someone looks inside with a telescope and makes the diagnosis, but it could be months of delay till they get a proper diagnosis. The ureter is the tube that connects the kidney to the bladder, and that's about 25 centimeters long, and it's about the size of a straw. That is true. And the urethra is more like the size of the pinky. The urethra is in the penis and underneath, going to the prostate. And in a woman, it's a little bit bigger, oddly enough. It's the size of probably an index finger, but it's very short. The bulbar urethra, which is the area between the scrotum and the anus, the urethra, it goes from the penis to underneath the scrotum to the prostate. That's where it typically gets injured because of either a traumatic injury, you fall, a straddle injury, or a catheter. They put a catheter in. Let's say you had an abdominal surgery. They left the catheter in for 3-4 days. Because the urethra makes a bend, it makes like a U-shaped bend in the bulbar urethra, that area between the anus and scrotum. That's the most injured site. And then when they take out the catheter, weeks to months later, then they develop a stricture, and they have trouble urinating and or even not urinating at all. When a patient is initially diagnosed with a urethral stricture, the most important thing is the length of the stricture. How long is it? How many centimeters? Location. Is it in the penis? Is it in the bulbar urethra between the anus and scrotum? Is it in the prostatic urethra? Is it closer to the bladder? And then the cause of the stricture, the etiology. Is it a traumatic injury? Is it an infection cause? Is it iatrogenic from a tube or something along those lines? So if it's very long, strictures usually over 2 centimeters in length, are not amenable to an endoscopic or minimally invasive success. So they need a urethroplasty, plasty meaning fix in Greek. So they usually need a patch from the mouth or skin or something along those lines. Patients who have strictures of the penile urethra also are not successful in terms of endoscopic surgery. So that's why location is important. So a patient who has a scar tissue in the penile urethra will need some kind of reconstruction, a flap of skin or graft to fix the urethra. and then etiology, so the cause. If it's a traumatic injury, a crush injury, car accident, that is not amenable to an endoscopic, minimally invasive. They need a open surgery to fix things. So in the general community, what will usually happen when the patient is diagnosed with a urethral stricture, the general urologist will say, oh, we'll dilate the stricture or cut it, and doesn't really evaluate the patient adequately in terms of length, location, and etiology of the stricture, because they could tell them a success rate. Look, if we dilate this or cut this, the success is 10% or 5%. But they're not evaluating the patient properly. They're not doing imaging and endoscopic imaging. They're saying, oh, we'll just go to the OR, cut it. If it stays open, great. If it doesn't, it recurs, I'll send you to someone else and they can deal with it. The problem is that every time you cut and dilate the scar tissue, it potentially can propagate and get worse. So the amount of fibrosis and scarring and length of this, so something that was initially maybe 3 centimeters or 2 centimeters, you keep cutting it or keep dilating it, and then it ends up much more complex and difficult to fix. So they're done a disservice being cut or dilated multiple times over the years. That's usually the case, that someone does an endoscopic procedure that was not indicated, that has a high failure rate, and then they keep repeating the same procedure that has a high failure rate. And then the patient either ends up in the emergency room, not able to urinate, or is just frustrated with the recurrence of having been dilated, going to the operating room, and wants a more definitive repair. So there are alternative options to doing extensive reconstruction of the urethra. One of them, as we mentioned, is endoscopic repair, or treatment, I should say, not a real repair. It's more of a temporizing treatment. So you can either cut the urethra with a telescope or balloon it, stretch the scar tissue. This new device that injects paclitaxel chemotherapy into the urethra as an alternative to this. For patients who are elderly or debilitated, undergoing a big surgery like a 3-4 hour general anesthesia surgery like a urethroplasty may be too much for them. So many times we'll put a suprapubic tube, a tube through the skin, right above the pubic bone, straight into the bladder, and they live with the tube, and they can plug it and unplug it, and many people have a normal life doing that. The other thing we do is, if the urethra is so complicated and they've had multiple injuries to the urethra and multiple surgeries, we do what's called a perineal urethrostomy. In other words, we just make a hole between the anus and scrotum and they sit to pee, instead of trying to reconstruct the urethra. And we usually do that in people who've had multiple surgeries, and it's just too complicated to reconstruct the urethra. And the last thing that people can do is they can catheterize themselves. So in other words, we can balloon dilate the urethra, and then they take a catheter 2-3 times a day, and they push it through the penis or urethra into the bladder, and they stretch the scar tissue. And that's one way of managing things, but the problem is it's cumbersome and painful, and it may increase your risk for infections and stuff. So that's usually not a great, as a temporizing procedure, it's reasonable, but something long-term, it's not a good choice, especially as people get older and their hands are more disabled or have arthritis. It's been an issue with some patients I've had who are do a lot of manual labor. They are construction workers, or they work as mechanics. They said, look, I can't catheterize myself. How am I going to clean my hands? And I can't do it in a sterile fashion. So for those patients, it's an issue as well. Yeah. The questions that most patients should ask are really how experienced their surgeon is. Have they done this surgery before? And what is the real success of this surgery? And have them quote a number, like your chances of success are 85% at 5 years. And that's the typical result of a urethroplasty. We say 85% 90% success at 5-year success. So if they can't quote you a number, then perhaps they're not very knowledgeable about it. So also to have realistic expectations of what the result is going to be. No surgery is 100% successful, but in terms of urethral reconstruction, it's about 85%. Most people who are not fellowship trained in reconstructive urology don't have a lot of experience doing these cases. So it's always better to go to someone who's experienced, who's surgically experienced, and has good results. You don't want to do a surgery that fails and then it makes the subsequent surgery even more difficult to do. So I think that would be the most important thing. Ask your surgeon, what's the success of the surgery? What's the recovery going to be? Because many people don't have a realistic expectation of how long are they going to be out from work and what's the recovery. And then the third thing is what's their personal success with the surgery and how many cases do they do on an annual basis, so you can go to someone where you'll have the best results, not a temporizing result. Yeah.